Class, we're going to be talking about Chapter 5, Communications. This is on page 95 in the Pre-Hospital Emergency Medicine Edition 12 book. As far as communication, I'm going to hop over this side. I'm going to kind of follow along with your book. I'll kind of bounce back and forth with the book a little bit, kind of the way that it really happens in the real world. So anyway, your book kind of talks about how we communicate on a broad spectrum as far as how does dispatch communicate with ambulance, how does ambulance communicate with the hospital, how do we communicate with the people that are on scene along with hospital and dispatch. So coming from this, you'll see stuff called a base station. So the base station is the main hub of what is linking all these different radio transmissions from one place to another. Typically they have about 80 to 150 watts, so they carry a large distance. You typically see these places that are on some kind of elevation with a clear view of the area that you're going to be servicing. So anyway, you have your base station here. It's usually located in good range to the hospital because that's probably going to be one of your main communication places if you're on an ambulance. And then it wants to be close to dispatch also. So your base station will have good communication with these two. And when you look at like your vehicle goes out, your vehicles, not all of them do, but some of them will have a transmitter on it. A transmitter kind of boosts that wattage so that it can send a message a little bit farther. Your textbook talks about 20 to 50 or 15 to 20 miles. I don't know what the repeaters and stuff are set up where I work at, but it seems like we do go out of the range of the repeater sometime, and sometimes we have to use cell phones to call to talk because the radios don't work anymore because we're out of range. But anyways, our vehicles do have mobile transmitters on them, but you can run out of that range, get too far away from your base station or the repeater. I put repeaters up here. So if like, where I work, it's a huge geographical area and there's not a lot of infrastructure. So whenever we drive to the far ends of the county where there's not a lot of people, we get too far away to communicate with the base station, and they don't have repeaters in these areas because there's not a lot of people in these areas. But if there's probably a bigger population, then they will put repeaters at different hills. These repeaters will take our communication from our radio ambulance to the repeater. Repeater will send it on to the base station. It's just if you got a bigger area to cover and you only have one base station. Okay, so that's kind of what repeaters do. When we look on down from the vehicle, we need to be able to communicate with the hospital also. So as long as we can communicate with the base station can link us to the hospital. And then handheld radios, those usually go on scene with us, right? So when we walk out in the ambulance, we have a radio on us. Highly encourage you all to make sure your radio's with you. At least one of you or your partner should have a working radio on scene all the time. If you work in EMS long enough, I'm sure you got caught with your pants down. Something happens on scene, your radio battery is dead, and you're trying to make a call on the radio. Instead, you're trying to use your cell phone. It just best practice to make sure at least one of you carry one that's charged and working at all times. Okay, cell phone's always good to have too. So this is kind of stuff that you might see on an exam as far as National Registry or something like that. So you should have a little bit of working knowledge of your base station, how communication takes place with dispatch, what mobile transmitters are, what repeaters are, and handheld radios, and how that little communication network takes place. Okay, moving on. This is a little bit of a hodgepodge of stuff in your textbook. So coming over here, your book mentions a bunch of little stuff just real casually. And to me, there's a lot of this like a mobile data terminal. Like I have nothing to relate to this in the real world. I don't know where this has been used at in any service I've ever worked in. I've been doing this for 20 years probably. Cell phones we use all the time nowadays. Very useful things. I know like even taking pictures of like stuff on scene and showing it to the doctors, showing it to the nurses, that sort of stuff. Making phone calls to the hospital works really good sometimes. It's nice to be able to communicate with like medical control or the hospital to tell them what's coming in as opposed to using a radio. It's just sometimes it's a little more fluid communication. So anyway, good idea to have the cell phone there, to have the ER on speed dial on there, something you can access pretty quickly. Other ways that we kind of communicate also is through telemetry. And telemetry is how we like send, or how we have in the past kind of like sent information from like our a cardiac monitor or sending a 12 lead to the hospital to get them to take a look at, see what they think. This is kind of changing nowadays though. So with like telemetry, like nowadays, the new cardiac monitors, the hospital can, if it's all linked together, they can pull up your cardiac monitor. They can see it in real life, real time. Like you take a blood pressure on your patient, the hospital can see it right there. You do a 12 lead EKG or a 3 lead on your patient, it's like the doctor can be looking at it right there in the hospital at the same time you're 30 miles away on the ambulance looking at it for the first time too. So some of this technology is moving so quick that your book is dated on some of this. As far as telemedicine goes, we don't really do a lot of that with EMS practice right now. There's a lot of like community paramedicine. I would say is something that you see more of this going on. But really, as far as us and EMS, like we're not typically pulling out an iPad and then having a doctor on the other end talk to our patient inside of like a home residence or nursing home or something like that. But kind of telemedicine, that's what it's used for. So like you can link someone of a different kind of knowledge, a higher level of care or something like that, and they can talk to you and your patient in kind of like a real life image there. Okay, I don't have a whole lot to add over land mobile satellites either. I'm not even sure where this, I have no connection, I've never used anything like this. Your book just kind of mentions it. I haven't seen an exam anywhere either, so we're gonna kind of move on past that. I'm gonna flop over to this side here. And as far as communication that you're gonna do with people, communication is one of the most challenging things for new EMTs. It is nerve-wracking to get on a radio and call into the hospital and know that like your voice, all the nurses, the nurse assistant, the admins there, the doctors, everybody is hearing your radio report, your voice, and it is nerve-wracking for everybody that starts doing this. And yes, people do tend to give you a hard time when you botch these reports. So what I encourage you all to do is like new EMTs is take a little second, write down, at least in your head, mentally, like what you want to say and how you want to say it before you pick up that mic and call the hospital. So as far as different kinds of communication, we communicate with dispatch. That's how we would normally get our calls. Tone goes off, some kind of alarm goes off, and we hear dispatch say, you're dispatched to a 64-year-old male complaining of difficulty breathing at this location. And then our next kind of communication usually takes place is like we acknowledge the call and tell them when we go en route. Most places are like 1 to 3 minutes in the daytime. Nighttime you may get like 2 to 5 minutes to kind of be en route, but we should be able to go en route pretty quickly. And then after we tell them we're en route, oftentimes dispatch will give us updates as we're traveling to the location, like police arrived on scene, scene is safe, patient's not breathing, police have put on an AED, they're doing CPR, 2 shocks delivered, just the kind of updates going on as we're getting to the scene. We'll often hear from dispatch. For those, we just acknowledge, like, copy. And then when we arrive on scene, we need to let dispatch know that we're on scene because they document our times for us. And then whenever we go en route, we need to let them know we're going back to the hospital. And then that time from when you go en route to the hospital, you need to call the hospital and let them know that you're coming and what you're coming with. It depends on the hospital. Like I worked in Knoxville for a while. They could care less what I was walking in the door with unless it was like a cardiac alert, a stroke alert, a trauma alert, a baby delivery. Unless it was some kind of like specialized thing they needed to get a special team for, they really didn't want to hear what I was coming in with. Here in Colorado, whether it be where I currently work or other place I work, like they want to know details on every patient I'm bringing in. For these, is what I'm encouraging you all to write your stuff down. When you call the hospital, like you're on the radio and there's all kinds of stuff going on in the ED sometimes. And so like when you call in, let them know what you're coming in with first thing. They don't need a whole list of all these vital signs of everything you did. They need to know what you're bringing them and what they need to be prepared to receive. Sometimes the vital signs relevant, sometimes vital signs not relevant. All of your treatments may not be relevant. If you did a treatment that like had some kind of impact, or there's some kind of drastic change in your patient, they're trending up, they're trending down, like big information. We'll talk more about this in the EMT class. We'll get y'all used to giving oral reports and that sort of stuff. Okay, so that's communication with the hospital as you're going there. hold on to this S-bar thing, because S-bar is gonna be once you arrive at the hospital. And if you're calling for like medical direction, you can call on the radio, you can call on a cell phone. When you call the ED, tell them you need to speak to a doctor. It has to be the ER doctor's on staff there. It can't be a nurse, can't be a tech. When you get the doc on, this is when you really need to have your ducks in a row, right? So you don't talk to the doc and be like, what do you think? I got this, I'm not sure. You talk to the doctor and you be like, I got a 67-year-old patient, he's complaining of difficulty breathing. I've gave him 3 rounds of albuterol. I'm asking permission to give him another 2 rounds of albuterol. It's like, tell the doctors what you got, what you want to do, and ask them if that's okay. They want a quick sum up of what's going on. So that's my kind of advice for calling medical direction. In the protocols will outline stuff you can do without calling medical direction. It'll outline stuff that you have to call medical direction for. Sometimes I arrive on scene and I'm just like, this is really crazy. I have no idea what's going on with this patient. And sometimes I'll call the doc and be like, hey man, this is what I got. I'm really not sure what's going on. I did this, 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 and this. Is there something else I should be looking at? So it's a resource for us. It's a really good resource too. Okay, and if you do call medical direction, guess what? This needs to be documented in your PCR, right? Who did you talk to? What did they say? This is all good information. As far as an oral report is like when you come into the hospital and you bring your patient into the room, and then the nurse and the doctor is sitting there waiting for a report. S-bar is in your book. I've never used S-bar. This is taught for all nurses. Every nurse in the country will know what S-bar is. This is how they give verbal reports. If you want to do S-bar and get used to giving your reports to the nurses in this fashion, they will love it. You can do it any way you like. You just need to cover the material. When you come into the hospital, that's when you give them a more detailed kind of picture of what's going on. You're not telling like allergies and medications on the radio when you're coming in the hospital. Once you get into the hospital, this is where the nurses, the doctors, they want a bigger picture of like what's going on, what's their medications, what's their past proven medical history, how's their ins and outs been, the whole sample thing, a full list of vitals. This is where you give a bigger picture of a report delivered to the next level of healthcare. Okay. It talks about taking charge in your book, and I think this is a learned skill. For me, it was a learned skill. You need to learn when to take charge, and you need to learn when not to take charge and take a back seat on stuff. I think the biggest thing I see from EMTs on like taking charge is sometimes it's hard to stand up in front of your peers and be the dominant one that's running the scene and be confident in what you're doing and be okay with making mistakes, because we are going to make mistakes. And the other big thing I see is people take charge, they want to do stuff. If you're taking charge of the scene, like sometimes you need to be the one to step back and be delegating stuff around. As a paramedic, I'm oftentimes the only paramedic on scene. If it's a big call, there's usually firefighters, there's usually police, there's another EMT. They usually have first responders. So for me, when I show up on scene, if there's like something critical needs to happen right away, if I need to get like Narcan on board, get an IV, get an IO, get an airway established, like I am involved in those skills. And then once I get some of these like critical things taken care of, I usually kind of take a step back, and it's usually like the firefighters and the EMT that's doing the vitals and getting the patient packaged and carrying them out of the house. And I'm usually taking a step back and kind of been the observer lots of times. So anyway, kind of knowing your role, know when to take charge, know when not to take charge. Okay, general kind of rules of thumb. Seeing if I missed anything here. We'll come back to other. But kind of general rules of thumb for communication on a radio. Your book talks about some of these. I thought it'd be easier just to put in real world perspective. So some big things to take note of is, number one, make sure you're on the right station. You will have to hop back and forth between dispatch, police, the hospital, that sort of stuff. So make sure the radio is on the right frequency there. And then whenever you do key up the mic, I see this all the time with new people, especially new ski patrollers. When you key up the mic, you gotta wait just a few seconds before you speak, because it cuts those first few words. If you just key the mic up and start talking right away, we miss the first few words you say. So key up that mic, give it a few seconds before you start talking. And when you talk, try to hold that mic about 3 to 6 inches away from your mouth. You put it too close, it gets muffled. You put it too far away, we can't hear that well. thing is be prepared. I encourage my students to write down what they want to say to the doctor, what they want to say to the nurse before they key that mic on that radio. In a busy ER like in Knoxville, you got about 3 seconds to grab that doctor's attention. If you haven't grabbed it in like the first like 3, 5, 6 words that come out of your mouth, that doctor don't care. They've already walked on, they got other stuff to do. So whenever you key that mic, be ready to tell them what you got, what you're coming in with. If it's a critical patient, grab their attention right away. I got a middle-aged male, unconscious, unresponsive, not breathing, we're ventilating for him. It's like that grabs your attention. I'm coming to you with a 76-year-old stroke alert, onset of numbness, tingling on right side 30 minutes ago. It's like this sort of stuff grabs that doctor's attention right away. I'm coming to you with a stroke alert, coming to you with like a trauma alert. Patient crashed going 70 miles an hour down the interstate. It's like that grabs someone's attention. So if it's critical, make sure that you get that person's attention right away. And try to keep these efficient is a good way to do it. They don't want to hear a report that's 2 minutes long. I can't. If you tell me a report over like 30 seconds, I'm going to forget the other 30 seconds of it. So try to tell them the most important stuff in a short amount of time. All right, coming on back, some things that your book mentioned is radio codes. Don't use them. This is a good one. Take them away. We don't use codes anymore. The whole 9/11 kind of did away with that because all these different agencies had all these different kinds of codes. And like 1076 meant one thing for ski patrol, and 1076 meant something different for the fire department, meant something different for the EMS service across the county. So just use clear English. That works best. And also we're talking about times for EMS. We operate on military time. So it's not 1:36 p.m. It's 13:36. So kind of keep that in mind. If you need to put your watch on like military time and get used to calculating it that way, I did that for years. That's a good way to kind of get used to it, but just keep in mind we're on a 24-hour clock in EMS, not 2 12 hours. There's some radio terms on 106 in your book. Some of those I kind of looked at, and we do use some of them. It's like clear last call, copy, ETA. We try to get away from like abbreviations or short terms of words, but there are a couple of them that are kind of normal, still accepted in the industry. Continuing on here, we're on your book now on page 106, like talking about therapeutic communication and like communication with your patients. I don't have any of this up here. It is just basic kind of communication with people. So we'll kind of talk about some of this different stuff that's in your textbook here. As far as talking to your patients, like they feel kind of what you give them. So there's all kinds of like communication, right? So like looking at a patient and how your body posture, like this tells us, that says a lot to your patient. If you walk into your patient and do one of these, all right, so tell me what's going on today. Like, what's that do to you all? That's probably going to have the same response to your patient, as opposed to walking in and making eye contact with your patient and kind of having an open body appearance to where like you're ready to accept their communication also. Depending on the situation, depends on how we have that communication. You can't walk into every patient expecting to communicate the same, which is a lot of the fun of the job. Oftentimes we're in places that's not very comfortable, not very clean. Sometimes they're dangerous places. We want to make sure that we got a quick exit out of the house or something like that. This does affect our communication. When at all possible, I try to get in eye level with my patients to where like they can look me in the eye and they can see my face. If those patients feel a connection to you, then that communication is going to be better. So that's, if at all possible, that's my advice to you all, is try to get on eye level, make eye contact with your patient. Whenever you're talking and you're asking questions, you got to kind of navigate to get the information you want to get without getting all the information you don't want to get. So your book will talk about open-ended questions. Explain to me what happened. Closed-ended questions is something where it has like short answers to it. Open-ended may go a long ways. Something that I use in my patients lots of times whenever I'm like, all right, I'm hearing a lot of like stuff, and you want to let your patients talk. You don't want to cut them off, but sometimes you're like, all right, I don't need to be here for 10 minutes, and you cut to the chase. So oftentimes I'll look at patients like, okay, so tell me why you called today. at this very time? If this has been going on for multiple days, what changed? Like, what made you pick up the phone and call me today? That's a good one that kind of seems to cut to the chase for me, as far as like, okay, now I know I'm here. So anyway, as far as communication goes, that's one of the tools I've learned a whole lot over the years. Other stuff, when we talk about like communicating with like older people, like lots of times they just want to know that you're showing them respect. I see a lot of EMS over the years that kind of look at elderly people and kind of discard them, and really they have fascinating stories, and they just want to be talked to. So the same kind of communication that you give these other people, you're going to give the elderly people the same thing. Sometimes eye contact with the elderly people is more important, because hearing does get bad as we get older. It's just part of the aging process. So if they can see you, they kind of tend to read lips over time, and you'll hear some interesting stories when you take these older people to the hospital. So sit and listen to them sometimes. If you get everything done, just let them talk, man. It's one of the best things we can do for our patients. When we talk about communication with like little kids, this is not my area of expertise. I haven't worked with a whole lot of kids, but I have worked with some people that are really good at this. And what I'll say for little kids is talk to them like you would any other adult. When they're really little and you want to like do something to them, you want to put hands on them, a BP cuff, you want to touch them, you want to start an IV, you want to do something like that, like try to get them involved and tell them in detail what you're doing and why you're wanting to do it. And if it's going to hurt, tell them it's going to hurt. We don't want to feed our patients inaccurate information. Having said that, like, don't give them false reassurance either. Never tell your patients everything's going to be okay. That's one of the worst things you can say. Something that I use a whole lot is like, we're doing the best we can. We don't know the outcome of this. Don't go in talking to your patients about some kind of disease and what this disease process is, or what kind of like treatment the hospital is going to give them. You know, it's like some of the words I use a lot through my career is just saying that, like, I don't know what they'll do in the hospital. They'll give you the best care they can, trying to give them reassurance that we're doing the best we can. The hospital has their interest at best, and we'll do the best we can for them. I know early on in my career, it's like I was an EMT doing my ride time as an EMT before paramedic school, and we responded to a car crash, and it was one of the worst ones I've ever been to, even to this day. This car got T-boned by a truck, and in the car there was 5 people. We arrived on scene. There was 2 people that was dead. They're all family members. There was 2 kids. One kid was dead on scene, and we transported the mom and I think it was grandma and another elderly person. The mom was critical, and the other kid got flown by helicopter to the hospital. And we knew the whole time that one child was dead on scene, and she would have had a really hard time parting with the kid. And I still don't know that we made the right call during that. And she kept wanting to see her kids, know that they're okay. And we kept telling her that the crew was doing everything we could, and the rest of the other crew on scene was taking care of her children. So that was a pretty hard one. It's like, did we lie to her because we kind of knew one was dead? We talked about that, and we opted to go with the communication we did, because that patient was very critical too, and we were trying to keep her calm, at least until we get to the hospital. We had more resources, because she's a very critical patient also. But what I'm just trying to stress to you all is, don't lie to your patients. Don't give them false reassurance. As far as other big things to talk about, communication with people that don't speak English is really challenging also. Nowadays, I know our iPad on the ambulance has an app where you can have an interpreter on scene there. So you can pull up this app and you can have someone in a variety of languages, whatever you pay for, and they can talk to the patients. That's been some of my more challenging things. I showed up at a mass casualty kind of one time, like 2 o'clock in the morning. I had like 20, 30 patients on a highway in the middle of winter, and none of them spoke English, and I don't speak very good Spanish. So that was a very challenging scene too. Everybody's yelling and screaming. I had no idea who was hurt. I couldn't understand anything they were saying. So yeah, communication will always be challenging with patients, but it also makes it very fun, because you're never bored. All right, that's all I got.